Okay, so welcome everyone to the Prevention Coalition of Mercer County. I'm Melissa Arnold. I see that Ruth Del Pino was on here for a while, but she is out of the office this week. So obviously I miss her a lot when she's not here because we're trying to a team.
You're a great tag team.
Right, a great tag team here. So obviously, February has a lot of interesting things happening. It's Black History Month. There are so many fantastic celebrations around Mercer County. And I encourage you to take advantage of that. It's Heart Health Month. It's Teen Dating Violence Awareness Month. I know I gave some data to Andy Gennaro. I know Assist is going to do something in Ewing, but that's something to keep in mind. One thing Anne was talking about was the link between substance use and how that can contribute to teen dating violence. Something we need to keep aware of. Next month is Women's History Month, National Drug and Alcohol Facts Week. If there are any schools or any organizations that would like more information or a presentation, a bulletin board, anything for that, just let me know. That runs from March 20th to the 26th. And then it is also National Gambling Awareness Month. So that's something to keep in mind, especially with the big game happening. Go Birds! Go Birds! All right. Yeah, as you can tell, I'm wearing my Eagles green. On my Eagles green here, my eyeshadow. So yes, something to keep aware of. They have a fantastic class that just anyone can take. You don't need to be a therapist. You don't need to be, you don't have to have any of those credentials. You just have to be interested. If you know someone or if you're concerned that there might be someone in your life who might have a gambling problem, they are a font of resources. And we will be having them check in with us next month for Gambling Awareness Month. I guess the only thing is, would our co-chair like to report anything? Andy Gennaro is our co-chair.
Thanks for being here. Greatly appreciate it.
Jay Shree, anything?
There.
Yeah, she's right here.
Hi everyone. I almost forgot the meeting. I'm so sorry. I'm at work. Good morning, everyone. So nice to see a good crowd sitting there and a good crowd on this side. Happy Wednesday to everyone. Thank you.
How come we don't see you, Jay?
Oh, I didn't realize. Can you see me? Hi.
Shree, good to
Hi.
see you. So without any further ado, I wanted to let our speaker have as much time as possible. Dr. Natasha Patterson from TCNJ. She's done a lot of work on a bunch of different factors. You have a book out right now on racism in public health.
Yeah, and mentoring
Students
through helping them navigate barriers and challenges.
We need all of that we can
take
do.
it to the career side of things. So, so how mentoring can be a tool and helping mentors reflect on their own, or potential mentors reflect on the possibilities of being able to help students and be culturally competent at the same time.
We love that. Thank you so much. That is absolutely one of our goals. And we might be calling you and getting some more insight on that. I appreciate that. So she and Dr. Sandy, I think I heard
Sandy Gibson.
Dr. Sandy Gibson, who we have actually, I think we've recognized through the PCMC, and she has come and presented to us before. They are doing a series of presentations on the drug war and some of the ramifications and some of the policy shifts that are associated with that. And when we heard that she was available, we said, yes, that's something that we want the PCMC to be a part of. So without further ado, I'll let you go ahead and take over, and then we'll proceed with the business side of the meeting, including introducing everyone and any announcements that somebody might have. All right. So y'all just hold tight. We're going to share this over here. And I don't know if you have sound, but we'll go ahead and do it.
And I see some familiar faces. Hi, Carol. Hi, Chris Freeman.
Yeah, we got a lot of TCNJ partners.
So should I stand somewhere so they can see me, or they're just seeing the screen?
Well, here's the camera. So if you want to stand
Oh,
there,
in
you're
here.
welcome to.
Oh,
and
okay.
I
I was
can,
looking up here.
and
Okay.
I can help flip this if you need to.
Oh, that'd be great.
But this
Okay.
is your mic, and I'm just gonna put that right
Okay.
there so you can hear it.
All right.
There you go.
All right. So, thank you for having me. Like I was introduced, I'm Dr. Natasha Patterson. I am public health faculty at TCNJ, and I am a professor who teaches health policy. I also teach health education and public health leadership courses. And one of the projects I'm working on with other faculty at TCNJ is this idea, or getting the concept in education around decriminalization, and sharing that information so that when it is time for you to make, decisions, you are informed in making those decisions about sharing that information, voting on different legislation, so you understand the concepts, and you can also share some of the language with other people in your network. So I'm going to be sharing just a little bit about how this impacts public health overall. I'm going to talk a little bit about the history of the war on drugs and the outcomes, and how decriminalization is harm reduction. So we know harm reduction is meeting people where they are, right? And trying to support in any way possible to lessen the risk, lessen harms, lessen illness and disease, and early death. So as a harm reduction strategy, we are sharing about the decriminalization of drugs, and I want to define it in the versus the everybody can do everything they want, right? So usually when we say decrim or decriminalization, people think, oh, people can just do whatever they want, they can break laws, they can do, X, Y, and Z, and that's not the case. So decriminalization means that we are shifting our focus to more of a support, social service, health, patient-centered mindset versus the criminal side. So there are different states, and I'll talk about this when I get to those slides, but there are different states who are doing it in different ways. Some of them have shifted where they are making it a civil matter. If you are caught with or have possession, or it seems like you may have an issue with addiction, then you are referred out to a social service organization, treatment and things like that, as opposed to arrested, as opposed to entering the system. Because what was found is that when people enter the system, it affects other aspects of their life. So it affects your parenting. You may get your children taken away. It affects your job or career prospects. So not being eligible or not being able to get steady employment because you have a record. So once you enter the system and you now have this record, it impacts every aspect. It makes it difficult for you to get assistance, Medicaid, housing assistance, things like that. So in order to help shift away from that and having those be the outcomes that affects you for the rest of your life, and make things more difficult for the rest of your life, and you having to make these tough decisions, shifting the focus more to a health focus, and a wellness focus, as opposed to a criminal focus. So that's kind of the perspective I'm coming from with this. And then I will also say, if you have questions as I'm speaking, feel free to share, and we can make this a dialogue and conversation as well. And if you have examples and stories, I would love to hear them also. Okay. All right. So. All right, so one of the perspectives we take in public health is an ecological perspective. So ecological is looking at action and policy from every level. So from the community level, starting from the individual. So you have the individual level, and we can make change at the individual level, right? We help people individually one-on-one, but then there's changes we can make at the community level and start looking at the immediate environment where people live and if that environment is conducive to them being healthy. Then we can also look at institutional. So are our schools, our different hospitals and institutions, are they supportive of this healthy centering? And then also policy, you know, how do our policies support this? So a lot of times we do, we create programs, we draft policy, and sometimes it's not in line with what we're trying to do with the individual. So we would like to help in certain ways, but sometimes laws and policies prevent us from being able to help in the way that may help the person. So we want to make sure all of those things align. So the ecological perspective is the individual and the community are considered at the same time and considered harmonious. So if we think about not just the individual and what their challenges are, but what's in their environment that is either hindering them or supporting them as they make healthier choices, right? So that's the ecological model. And it takes in consideration that sometimes there's not one single factor that impacts people, but many. So that means that our solutions also have to be complex because our problems are complex, right? So just a little bit about public health in general. So public health, for those who don't know, is basically the field where we focus on the population. So I like to compare it to clinical medicine. So clinical medicine, you have a physician, you have a nurse, you have a physical therapist, and they work one-on-one with a patient. Public health, our patient is everyone. So everything we do is on a population level, it's on a community level, it's on a group level. So sometimes the decisions we make have to be for the betterment of the population. And sometimes that's hard to do. But we are assuring the conditions in which people can be healthy. That means that we are looking at environment, we are looking at access, we are looking at equity. And then for this particular talk, my focus is the policy development piece. So we do assessment where we diagnose illness and disease, we study it, we find out how it started, who it started with, and how we can treat it, right? So that's the assessment piece. The policy development piece is when we use scientific knowledge to develop a strategy for approaching communities and making them more healthy. And then assurance is when we maintain. So we assure that we can continue this process, we can continue this program through funding, right? That's a big piece of a lot of what we do, is making sure we had the funding to do it, making sure that it's in the budget. If it is something that is funded by the government, if it's something that's funded by foundations, you know, how do we ensure that we can continue this work? Because continuity is important when we're providing services. So policy implications when it comes to the health of the community. So we have policies, some of our policies are based in exclusion. They were developed with only one subset of the population in mind, and then later expanded, and there may have been additions and revisions to policy to include others, but from the get-go, it was based on exclusion, right? And oppression. So that creates structural barriers. And when we say structural barriers, think about applying for something, right? So say you want to apply for health insurance coverage. Say you want to apply for Medicaid. What's the first step in trying to do that?
You need an address.
Identity services, proof of address, residency.
Exactly. So those can be structural barriers. Those can be things that are in the way of people having a seamless transition into this process. So I may have issues with my identification, my driver's license. I may be unhoused, have challenges around housing, might not be able to receive mail there. You know, there's so many different nuances. So those structural barriers affect everything from there, right? Systems based in racism don't need to work within the system to be racist. So when we talk about systemic racism, we're talking about the system itself, not the people. Anybody can carry out those policies. Anyone. You can look like anything, have any kind of background. As long as the policies and procedures are in place, anyone could carry it out. So that's why we have to focus on the system and not necessarily the people so much. Because when we cherry pick, we're not changing the system. We're just picking on different people who carried out those policies. So we want to make sure that the policies are what we're changing, because that's going to stand the test of time, right? So people change positions all the time, change roles all the time, but if the policy still stands, the policy still stands. So that's where our change needs to be. A system is built to create the same outcome over and over again. So we're constantly questioning, like, why does this keep happening? Why does this keep happening? Because the system. And if we don't ever address it in a systematic way, then it's never going to change. It may change. It's like when, if I use higher education, you know, I work in a college setting. If we have policies about students being able to register a certain way, and there are students that have challenges with that, and they're constantly having these challenges, I, as an individual, might be able to help them get around it. But if I leave, the next person might not, because I didn't change the system. I changed the way I did things so I can help them. And sometimes we find ourselves doing that. We change what we do because we know the system is not gonna, it has these barriers. So we help individuals work around the system sometimes. But if we leave and they come back and we're not there, they may not get that same help. So that's why it's always important to focus on the system, the policies, the practices, the procedures, because that will make sure that there's continuity and people don't have to luck up on a really good person that's helping them, right? It'll just happen over and over again because it's in the policy now. So some of the things that these things impact is our social economic system, you know, our what we pay for. We have challenges right now with housing. You know, we're in a housing crisis, you know, across the nation, pretty much. We're in a housing crisis. People cannot afford to live. People cannot afford to pay. The rents are going up. The space is getting smaller. You know, there's just a lot happening. There's a limited options. I know there's limited options. We have a large elderly population, and we don't have the housing to meet that need. When we have a large elderly population, that means we have a large number of people who are on a fixed income. And when you have a fixed income, you are not able to pay $1,600, $2,000 a month for a studio apartment or one bedroom apartment, right? So, and then we have issues around assisted living and the cost of that, you know, and whether you have private insurance, Medicaid, Medicare, all of that, that creates a challenge as well. So we have all of these policies, how policy impacts what we call social determinants of health. So our social determinants of health are those things that don't immediately appear to be health driven, but they impact your health. So your housing impacts your health. Where you live, your zip code impacts the decisions that you make about your health. Your employment, whether or not you have paid sick time, you know, that impacts how people make decisions about their health. If I'm going to take off from work to go to a doctor, if I have a pain and I need to go to the doctor and the doctor's office is open between the same hours that I work, am I able to take off of work, still be paid, not lose money, and go to the doctor, right? And it's not even that simple. It's transportation. Do I have the transportation to get there? Do I have the copay? If there's a copay I need to pay, you know, so there's all of these different, and then when I get to the doctor, they may make me sign in on an app and fill out information on an app. Do I have the phone that have the data? Do I have that capability of downloading this app? Do I understand technology to the point where I can fill this out on my phone? So there's a lot of steps in between. So go to the doctor is not as simple as it sounds. So there's all these different implications. And then we also have other layers. We have age, we have race, ethnicity, gender, education, income, housing, workplace, neighborhood, schools. All of these are layered on top of each other every time we are addressing a problem. It's never as simple as it appears to be. So we get to this, the phrase and the practices of the war on drugs. So the war on drugs is now over 50 years old, these policies, right? 1971, President Richard Nixon declared drugs #1 enemy. But what happens if you declare a war on an object? It inflicts the people. So the people suffer from the policies. It hasn't really, they've shown that the outcomes have not met what the original goal was supposed to be. The war actually impacts families, generations, communities, and for an infinite amount of time. Do we declare war on heart disease? No. No, we talk to people about heart disease. We tell them what their risk factors are. We tell them what the options are if they find out that they are at risk for heart disease and stroke. It's Heart Health Month right now. The conversation is loving. It is a heart, right? It's red. It's, you know, they just partnered with Damar Hamlin to promote CPR. And if you don't know him, the football player that fell, that just had a cardiac arrest on the field. And it raised a lot of awareness. So they're both partnering to get more people to do CPR. But it's this, right? Why don't we have this for addiction? Why are we not like this? Why is it not this loving conversation? Why is it this stigma associated? Why is it violence associated? Why is it criminal prosecution associated with it, right? So we do the same thing here. We don't declare war on cancer, right? You see breast cancer, it's pink. You got pink ribbons, everybody's walking arm in arm, you know, doing a breast cancer walk. So when we look at health issues down the line, and then we look at addiction, it's a very different conversation, very different tone. So when we talk about this, you know, in this war on drugs, it really wasn't focused in a health way. Like it wasn't from a health perspective. So then it became more criminal. So you had no-knock warrants, you had increased arrests, increased convictions, mandatory sentencing, increased prison population, children being removed from their parents' custody, a ban on funding for syringe exchange programs, the crack house statute. All of these policies came out of this. So when you have all of these policies that are not necessarily from a health perspective, you're going to have negative health impact because health was not considered when these policies were developed. So the impact of that, the cycle of trauma. Increased mental health concerns, instances, generational damage, community damage. Drug overdose and ER visits associated with illicit drug use actually increased after these policies were enacted. Marginalizing and stigmatizing drug use leads to worse outcomes, including risks for transmitting other diseases like HIV and hepatitis C. Increased incarceration for mostly marijuana possession, cannabis possession. Black people were almost 4 times more likely to be arrested. Differences in sentencing for powder cocaine versus crack cocaine. A health in all policies approach would have a positive impact on these. So when we think about policy, while on the surface, it may not look like a health policy, but if there are health outcomes as a result, It is health policy. So we have to consider, and we've even seen this in development of streets and sidewalks. So we now have public health people working in those areas because where are you putting the sidewalk? Where are you putting the Wawa? Where are you putting this new building? And how does it impact walkability? How does it impact toxins in the air? Is it gonna create more pollution? Is it gonna create more traffic? Is it gonna make it harder for people to be healthy and make healthier decisions? So when we take a health in all policies approach, that means that even though we're looking at something that might seem to be more on a criminal justice side, what are the health implications of this decision and of this policy and of this law? How can we make sure that people are not harmed by this? So those are the questions we have to ask. So when we think about the public health framework, so public health acts in a different way where our focus in the middle is evidence. What has been done. That's why we constantly look to other states. We look to other countries to try to figure out how are they doing this and if they're successful at it. And if can we do it here too, right? So there's a lot of reporting out from other states and countries about what has been done. So we consider the evidence, we consider research, we collect data, and we use that to drive our decisions. We do community assessments, community needs assessments, community health needs assessments. Every county has them, every city, and they basically compile all of the information about health issues. How many people are suffering from asthma? How many people are suffering from diabetes? We get all that information and we use that to make our decisions on what we're gonna do. And then we go around the wheel. So we make sure that it is a priority. We just develop this concise statement that this is a problem and why. We search for the scientific literature. So we're looking in journal articles, we're looking at research that was done to support us in our next steps. Then we develop a program or a policy. We develop options. We figure out what are the different ways that we can address this issue. And then we develop an action plan because now we have to do something. Sometimes, in some instances, we do all of this and then we stop here and then the action doesn't happen. So we have well-intended intentions and we want to do great work and we want to help, but we stop here. So we say it's a priority. And we say, these are the options. These are the things that we can do. But then where's the action? Sometimes the action stops because funding, right? Sometimes the action stops because understaffing. We want to do this work, but we don't have enough people. We don't have the manpower to do it. But we get to the action part. So we actually put it into place. Then we evaluate it to make sure that it's doing what we set out to do. So we always want to constantly evaluate and then we start all over again. We keep it going so we can stay up to date on what's happening, what's working, what's not working. How can we change it? How can we revise it? Yes.
I would like to throw in there as something that frequently stops you at 5 is stigma and public ignorance.
Yes.
And you have the best documented harm reduction strategy in the world. You can have all the justification.
Yes.
You can cross your T's and dot your I's. And guess what? There's going to be a syringe exchange in my neighborhood.
Right.
Because there's already needles all over the streets.
Mhm.
It would actually make the problem better. But the problem is it's giving them a safe place, to
Exactly.
party or whatever. And that it's public education becomes such a vital part of public health.
Mhm. And that's why a lot of times when we are trying to implement programs, prioritizing programs and policies, maybe we need to start younger. Maybe we need to have some educational, like robust health education in schools. Because that's once people are exposed earlier, we have a lot of our children are getting educated on TikTok.
Mhm.
Some of it's good, some of it's not. But if we had something that was more streamlined and more curated for them in K through 12 at different levels, at different developmental ages, understanding what they can ingest at different times, we can do it at the school level. And the more that they are exposed and what they understand, what they learn, they can apply later. Because the whole goal is to make informed decisions, but I can't make informed decisions if I'm not informed, right? So having a more robust health education program that's not just focused on sex ed and gym, right? So we want something more comprehensive that talks about mental health. You know, if students don't understand how to even recognize, sometimes they walk into school and they have a stomach ache and don't know that that's anxiety. Or they have other symptoms and don't know that it's depression. You know, if you can't name it, you can't help yourself. So when you understand that all of these different factors exist and then you don't feel isolated, it's like, oh, this is what it is. I can name it now. This is what that is. I'm thinking I have GI issues, right? No, I'm reacting to something. There's something happening in my life and I'm reacting, and my body is reacting to it, right? So when we give them the tools that they need, then they can do better with making decisions for themselves and understanding where to get help, providing them with resources, understanding there's no, you know, trying to remove the stigma from getting help, what that looks like. This idea of I can do it all by myself, you know, is harmful. Or that I don't need help, that getting help is weak. You know, all of these things are harmful, these myths about what we can and cannot do. And a lot of times when what they see looks like people being perfect and they don't feel perfect. So then that reflection further stigmatizes them. It further, you know, makes them feel less than, right? And we don't want that. We want them to understand, like, you're not alone. Like, there are so many people going through so many things. There are, you know, there's a lot of stressors on young people at different levels. You know, I have it with students now, you know, in college, and a lot of times they feel isolated, but don't know that there's several of your classmates going through the exact same thing, but nobody's sharing about it, so you don't know. So that whole feeling of isolation, perceived isolation, because there are others who are dealing with the same issue as you. And there are resources out there that can help you. And you shouldn't have to feel bad for seeking them out. So that message starts earlier. Then we can start to see some changes. All right. And then when we talk about the war on drugs and we talk about systemic racism, I just wanted to point out the American Public Health Association and the CDC have declared racism to be a health crisis. It's a health issue. It is something that is used to create barriers, to unfairly advantage some and unfairly disadvantage others. And it is impacting our health system so much, creating different health disparities, the quality of treatment in different areas, the social determinants of health around housing and needs and addressing resources. You have somebody in the waiting room. All right, so some statistics about the war on drugs policies. So the US spends more than $47 billion a year on just the criminalization of drugs. So any criminal, from trials to, you know, from arrest trials to incarceration itself. Almost 93,331 overdose deaths were in 2018, which was 60% due to fentanyl. 1.6 million or over 1.6 million drug law violation arrests in 2018, 86% was for possession only. 27% of the arrests are Black people, despite Black people representing only 13.4% of the population. And then, of course, in 2020, we had the pandemic, which exacerbated our concerns even more, where we had overdose deaths exploded during that time period and saw more than a 60% increase, from the isolation to advanced mental health and not being able to get into care. That was a huge barrier for not being able to get into care, not being able to get access to resources, being isolated. So we saw this jump. So you can see from 2015, if you look at 2020, we're all the way over here. So we have the baby blue kind of color is all opioid deaths. The pink is synthetic. And then the blue bar itself is the overall total deaths. And then we see the overdose death spike at the start of the pandemic and stayed high throughout the end of 2020. So we see this spike here. So this is February 2020 right here. So you see just before, and then you have April is right here. You see and then it kind of the dips, but it's still high from here. So it's still higher.
Just a reminder to please mute yourself. Just a reminder to please mute yourself. We're just, we're sharing control of the screen and I don't want to take more time away from Dr. Patterson. Here we go.
All right. So mass incarceration, the criminalization of drug possession is a major driver for mass incarceration. So you saw the stat 86% was for possession only. So you have this large group of people that are in prison for possession. Each year, U.S. law enforcement makes more than 1.5 million drug arrests. And this is more arrests than for violent, this is more than violent crime, all violent crimes combined. The overwhelming majority, more than 80%, is for possession only and involve no violence. So let me skip, because it's just in the interest of time. Let's skip to, so here's the harm reduction, which I'm sure you all are familiar what harm reduction is and the other ways that we use harm reduction. And this is what I like to tell people when they try to argue against harm reduction, because they immediately say harm reduction and needle exchange, and they put them together and it's this huge conversation. But we use harm reduction every day. You know, understanding that there are activities that put us at risk for certain health outcomes, negative health outcomes. How do we reduce that risk? That's the basics of it. It's not activity specific. It is across the board behavior and health outcome. So we use it for sunscreen because people are not going to avoid the sun, but we know what the sun can do to your skin, right? So we put out sunscreen, right? We use seat belts, speed limits, birth control, cigarette filters, and even some of like the patch and things like that. We have a lot of different things that we use. Condoms. You know, we are trying to address the issue of transmitting STIs. You know, there's the way you cannot transmit an STI is not have sex, but people are not having sex, right? So we have all of these different ways that we reduce risk. That's what harm reduction is. It reduces the risk. It meets people where they are. And, you know, it focuses on positive change and working with people without judgment, without coercion, without discrimination, and not requiring that they stop doing what they're doing. If they're not ready to do that at this time, we are supporting them through this process while reducing harms to them and others, right? So this is more, so then we look specifically at our state. So New Jersey arrests, New Jersey, 8 out of 10 people arrested for drug-related crime in the past decade were arrested for having a small amount of drugs on them. Black New Jerseyans were 2.6 times more likely than white New Jerseyans to be arrested for personal substance use. Drug decriminalization will decrease racial disparities, has decreased racial disparities in Oregon. So Oregon, like I said, we look at other states and we look at other countries. So Oregon has already done this and had some positive outcomes with their rates. Economics, so we know the money factor is always a part of decisions. So U.S. annual drug-related criminal justice expenditure is $25.7 billion, with more than $3.3 billion annually to incarcerated people charged with drug-related offenses. There's a lot of money we spend, a lot in New Jersey alone, $715 million in 2019 for arrests, trials, incarceration of people with drug-related crime. And an overwhelming majority of this associated with small personal use possession. I'll share this with you.
Oh, can you tell?
Yeah. All right, so I'm gonna skip over. Okay, I wanted to really talk about Portugal. So Portugal, anybody familiar with the Portugal model? I'm sure a lot of people in here are. So the way that they shifted their policing efforts is how they improved their numbers. So they shifted their focus from individuals to the distribution side of things, the drugs coming into the country. So how are the drugs coming into the country? Let's focus there, right? And by doing that, they focused on trafficking syndicates. They were seizing tons rather than kilograms of illicit drugs. And they got to it before the market. So you see their numbers going down based on what they have done. So we have the policy shift did not lead to increased drug use, which people thought it would, because they stopped focusing on individuals. And they stopped focusing on small drug sales and individual drug sales. So they were able to get people into care. They were able to provide more funding for treatment and support. So they were able to shift their focus and their funding to providing treatment and support. And because of that, they've decreased. So their drug-induced deaths per million has decreased. So they're all the way up here, Portugal. The US is down here with the most. And then you see then and now, this goes up to about 2017. So overdose deaths decreased. New HIV diagnosis due to injecting decreased tremendously. Number of people incarcerated for drug offenses went from here to here. So just by shifting the focus from the individual. So remember when I talked about the ecological model, you had the individual, the community, the environment, all of that. They shifted the focus above instead of just on the individual. And by addressing those issues at a more global level, they were able to make those changes. Now, some changes in for New Jersey. And this is based on a survey from people living in New Jersey. So New Jersey residents rate opioid overdose as a very serious problem, so 71%. They also believe heroin is the most dangerous at 85%. Nearly 8 in 10 say that the issue of drug addiction and overdose is important. So that's promising if everybody kind of sees it, right? 62% are concerned with opioid abuse in their own community. More than 3/4 are concerned with it, drug and opioid abuse in their community. New Jersey residents are more likely to blame individuals for drugs in opioid crisis. After individuals, they are more likely to blame doctors for prescribing drugs. The top value statements included in this survey: people need to be able to access treatment that work best for them, since different approaches work differently for people. So 58% believe that, 58% who took this survey believe that people deserve access to treatment that works best for them. Treatment services need to be available, accessible, affordable, and evidence-based. 54% agree with that. So a little over half, right? The top public health policy after hearing this message among adults in New Jersey is general harm reduction. 52% said they were strongly in favor. That's 52% of people that took this survey though, right? The least favorite public health policy, safe consumption sites. Not a surprise, right? 23% said they were in favor. So when we look at using decriminalization as a form of or strategy for harm reduction, we stop criminalizing people for drug use and possession. But based on that survey that I just shared about, a lot of it has to do with education. So we need to be educating people about what it is that these strategies are and what the goals are. And even in the way that I'm doing this right now, we're going across, me and my colleagues are going across the state sharing this information. And we're sharing it with groups like yours, but other groups who have no stake or they have no experience, the experiences that you all have, they don't have that. So this is one of the spaces where you all have a lot more experience than most of the groups that I've seen. Yes.
I was just wondering, like, how has the response been
Mixed.
to your presentation?
Mixed.
Yeah, I'm wondering.
Yeah. I actually was surprised. One of the groups that I met with was community health workers. And one of them, and I'm not gonna say all of them, because I've met with different groups of community health workers, but there was this one particular group of community health workers who didn't agree with any of this. They didn't agree, they just didn't want, they were frustrated. They were frustrated with people not getting into care, with barriers, but they also blamed the individual. So their perspective was a little different. And I was surprised by that because they were community health workers. And I made an assumption because they were community health workers that they would automatically understand. But that is not the case. And that also teaches us that we can't assume what people understand, what they, because what they see is the individual. And they're on the ground and they're doing a lot of work. And they're coming home and they're seeing their neighborhoods and what it looks like and how it's impacting them and their families. So it's very individualized. This is more of a global view. This is more of a widespread. So like I said, with public health, we think about population, community groups. But if you're an individual and you see your individual experience, that's what you're going to focus on. And that's what we have to speak to when we're educating people. We have to understand that they're seeing things from their individual experience. And sometimes they haven't moved to that what's best for everyone perspective yet. And you have to educate them into helping and understanding them, helping them to understand that this is bigger than us individually, right? And how it does affect us individually, even though it's our community. So I just finished with this statement, the people we love. When you or a family member is sick or in pain, the number one priority is getting well, no matter what the condition. For people we love facing addiction, proven and effective programs like medication-assisted treatment, life-saving protections from overdose like naloxone, commonly known as Narcan, are out of reach because we put prosecutors and criminal courts in charge of an issue that requires rehabilitation and treatment. Instead of relying on failed policies that prevent many from seeking treatment or lock people away for mistakes, we need to embrace smart evidence-based approaches that save lives and give our loved ones the chance to heal and recover. And with that.
All right, thank you so much. Do you mind taking some questions?
Yes.
Okay, thank you.
Oops.
There's a lot of great information here. Sometimes we need to be reminded of it.
Yes.
What a cute picture. All your pictures are great. Dave.
So Dr. Peterson, I'm very curious what your response has been presenting this type of material to the medical provider community.
Mixed.
Not the trenches level,
Right.
The hospital staff, the nurses are generally far more progressive and less stigmatizing. One of the anchor points of stigma and roadblock to all of this process is provider stigma and provider ignorance, not treating addiction differently than any other medical condition that they are ethically obligated to do no harm. And they are actively doing harm by pushing people out of emergency departments, not initiating MAT, not doing that sort of stuff. There are pockets of brilliance and progression in that area in different portions of the state. And we happen to live in an area where that is not the case in Mercer County.
Yeah, and we are seeing that. We are seeing that. And so one of the other parts, so this is one project we're working on. There's another project we're working on where we're building out a harm reduction curriculum. And we've been talking to medical staff. Yes, we've been interviewing nurses, physicians, different medical, PAs in the emergency rooms, emergency departments. And we're trying to gather all of the information that we can so we can build out this training for them. So we are, and they're saying they don't know. To us, they're saying we need more training. We don't know.
But they don't know,
Exactly.
you know, and that's the thing. There have been countless presentations and best practices and, you know, with the changing drug supply, fentanyl, you know, long half-lives, you know, complicating MAT initiation procedures, having to move to innovative techniques like microdosing,
Yes.
treating xylazine, you know, which is a co-occurring addiction and secondary withdrawal. That is something that nobody seems to know how to do except a few centers of excellence around the state. And that to me is terrifying, that these are the people that are making the decisions,
Yep.
you know, and influencing policies and throwing people back out on the street, you know, rather than, you know, at least linking them to harm reduction services.
Right.
You know, so I think that is a huge area of focus for education, you know, among the most educated.
Yeah,
And
exactly.
it's paradoxical
Right.
to me,
Right.
and very disappointing that they're so close-minded in
Mhm.
general about it.
Well, and again, that's the medical education system that needs
Yeah.
changing at that very beginning level when they're getting trained, when they're
You're
going
doing
into
field
medical.
triage
Exactly.
and helping them rethink
Yes.
what has been ingrained to them as medical culture.
Yep.
And that's horrible that you have to have that burden.
And the change has to happen kind of almost in a sandwich kind of way. It's like those who are already out there doing the work, training them, but then also getting in on the ground floor when they're first getting into school and training them at that level as well, so that we can kind of fix it and eventually we can lessen.
Squeeze it. I'm not sure.
Yeah.
All for it.
I was wondering if you've given this talk to treatment providers. There's also some systemic issues there, not only with, you know, built on racism and oppression, but also the idea of like abstinence
Yes,
only. And,
yeah.
you know, how has the appetite been with treatment providers?
We have some pushback, a lot of pushback, and then some that are actually willing to think about it more and think about it from a different perspective. But yeah, there's a lot of that, and there's a lot of that coming out of the conversation we're having when we're building out this harm reduction program, is that, you know, this understanding that the coercion piece, you know, it's like, it doesn't have to be abstinent only. There's so many different ways, and that's what harm reduction is. And some people say that they're practicing harm reduction, but they're not.
Yeah, and you know, and thinking that our treatment systems turn people away for the reasons that they are supposed to be there, right?
Mhm.
So,
Right.
and if, you know, hopefully we have decriminalization, but our treatment systems need to catch up because there's going to be an increased demand, right? And we need to be able to meet that.
Definitely, and we are working on that, and we have heard that, we've received that feedback as well.
I think it's important to realize that a lot of progress has been made increasing access to, you know, in particular for uninsured, presumptive eligible, and Medicaids, you know, which, you know, today's lifestyle, there are no 20-year professional functioning heroin addicts like there used to be. In the era of fentanyl and xylazine, you are rapidly homeless and phoneless and disadvantaged and suffering from those things that prevent you from even applying to Medicaid.
Right.
And it's a death spiral. So we have done a lot at the state level to increase the bed count and extend it to even long-term Medicaid care at a few facilities, to realize that it takes longer time than 1 or 2 week a detox or a short-term residential to effectively start a program of change. But one of the most disadvantaged and I think overlooked areas is Medicare, both for the disabled because of co-occurring, and the senior population that got hooked on opiates through the overprescribing of pain meds. You know, and you try to find a Medicare facility, all they'll pay for is a detox, which means they're going to have a clean system come out, and if they use again, they're a high likelihood of overdosing because they don't have residential options for seniors in Medicare. And that's another area where I think policy changes can be so important. More people are ending up disabled on Medicare, and that becomes their primary.
Right.
It's horrible.
Right, and it's a very challenging system to navigate for them, definitely.
I guess one of the main questions when I hear a presentation that has great information like this is, as a community group who is focused on prevention, but understands, you know, that harm reduction is absolutely part of that. What can we do to help make some of this systemic change? What are the acts? What are the
the action plans that our community can fit into.
So it's whatever you have access to, using that, using your role, your platform, your space to educate. And to also, messaging is important, and a lot of things we do in public health, we focus on health literacy and literacy in general. So how to explain things plainly so people understand and comprehend is important. So your messaging, so sometimes we have our own language that we speak in our fields, and we have to be careful not to use that language when we're talking to the general population. So making sure that the messaging is tailored to the group that you're talking to or whoever you're talking to, but using your platform, I don't know what everyone does here, but using your space, your social media, your platform to share out information and resources, and try to normalize it as much as possible, you know, and try to engage people in the conversation so that they can ask the questions that they need to ask to be more clear about what these strategies are and why they are important for us to be able to support them.
I noticed one thing that you said, like a lot of us resonated. I saw Anne shaking her head in particular. Anne DeGeneres, she's from Lawrence High School. When you mentioned the systemic issues and how several of us have workarounds that we've constantly done, but when we leave, those things are gone.
Right.
And I think that really speaks to what we want. We want to be able to speak to the system and make those changes so those workarounds are available for everyone and so things can be more accessible. One thing you mentioned just in your question and answer is your harm reduction curriculum. Now, would that be for the public? Would that be for schools? Would that be for medical professionals?
So right now we're building it out for medical staff, peer recovery specialists, supervisors, patient navigators, and we're working with Vital Strategies on it and DMOS, and JPN.
Okay.
Yeah. So, and we're building into it a cultural competency piece for us to address a lot of those issues as well that create, you know, systemic barriers and understanding. And we're working with someone from Oregon as well, because they have a wonderful program. So we're going to try to partner with them and see how we can integrate that here. We would have to adjust a lot of our language around what New Jersey does and New Jersey laws and policies and stuff like that. But we're doing a lot of research around this and a lot of partnerships so that we hit all of the areas we need to hit in the different populations. But I will definitely take that back to Sandy. We have a meeting tomorrow about broadening our target audience and population to more, you know, what can we do in schools? What can we do in different practice areas outside of hospitals and stuff like that?
Right.
Yeah.
And it is something that, you know, we as a group have tried to prioritize the role of of harm reduction, meeting people where they are. Obviously, that's part of cultural competency, but yeah, a uniform curriculum to bounce off of would be great. I know the people here in the room are dominating the questions. Are there any online? Are there any more questions here? I feel like we could talk about this all day.
Yeah.
I do have a couple more if nobody else does, but that's only if nobody else does.
Hi, this is Jayashree. So, Natasha, I'm sorry I didn't get the complete presentation, but you hit certain great points for me. And we're part of Project Graduation. Would love to meet you and talk about how we can help integrate your research in our school. So looking forward to talking to you soon. Thanks, Natasha.
Thank you.
So I guess one of the questions I have is quite often Portugal is held up as the standard.
Yes.
I know, as I said, we've worked with Sandy Gibson before. We've had conference calls with some policy officials there, which is really cool. And you see some of the really positive impacts they've had. However, one thing that that I always reflect on and people that I talk to reflect on is what systems did they have in place before? I know
Right.
healthcare is
Right, is
a
different,
huge
yes,
issue here.
yeah,
So I was just wondering,
Yeah.
like, what were some of the foundations?
right. So
In
the,
order for that to
and
happen.
that's a great question, because that brings me to Oregon too.
Mm.
So Oregon wasn't as successful as they would like for that reason.
Mm-hmm.
So Portugal, of course, their healthcare system is very different. The supports as far as like treatment and getting into care was easier than it would be here in the US, just because of our complex US healthcare system. That's what happened in Oregon. So they decriminalized drugs, right? But they didn't shift the support and funding to treatment as they should.
Mm.
So they shifted some of it, but it wasn't enough to handle everybody. So they had some failures. I did a presentation at the American Public Health Association conference in November, and I had people from Oregon coming over to me, telling me what was happening and how they were able to, so the decrim policies should include funding for support.
Mm.
And they said it did not. And because of that, there were people that were just out of, they were not receiving treatment, they weren't receiving help, they weren't receiving connections and referrals, and it kind of flopped in that sense, because they didn't see the numbers they thought they were going to see by decriminalizing, because they didn't have both pieces together. So one was creating this civil, instead of criminal, the civil outcomes and process and procedure when it comes to drugs. They didn't do the social service side of things.
Yep. And we're seeing
So
that.
they didn't support that side. So because of that, people did not get into care as they could.
And the point about comparing a nationalized healthcare system that had a foundation,
Right.
and then putting a
Right.
intelligent harm reduction strategy and decriminalization, Portugal. In Oregon, the way it was supposed to work was, all the money that we saved from prosecution was going to go building out
Exactly.
additional beds and treatment facilities.
Exactly.
And some of that has happened, but what was lacking was that middle link,
Mhm.
right? What was lacking was that connection to peers and social workers and clinical that could help facilitate that transition.
Yeah.
And as a result, they were getting less than 1% of the people that got the benefit of the lower
Yeah.
level of crime
Right.
actually calling the hotline, which was woefully understaffed.
Yeah.
And so it was the linkage point that was missing,
Mhm.
in that scenario. And so that should be a huge lesson to any
Oh,
state
yeah.
that is considering decriminalization, is that you need like strong investment in peer recovery services, and it has to be mandatory, measurable, and trackable.
Right.
That if you get this lighter degree of legal consequence, you are monitored and followed through that referral process, even if your chosen option is just harm reduction,
Right. Right.
So.
And that's the evaluation piece. So when we
Yeah.
talk about policy development, we talk about implementation, we always want to evaluate to make sure what we set out to do is actually what's happening. And then if it's not, where do we make changes? Where do we correct it?
It's a new gig, right?
Exactly.
We learn as we go. We
Exactly.
measure and be smart.
Mhm.
So this is kind of coming at the end here.
Yes.
And most of us are professionals in the field, but would you just try to give a definition that we could probably use? You're using the term decriminalization,
Yes.
and New Jersey understands legalization,
Yes.
but they're very different. Can you give just a quick, like-
Like a quick.
what one means versus the other?
Oh,
I
yeah,
make it-
yeah,
I
yeah.
make it
So
up
I
as I
do,
go kind of
right,
thing.
right. So
Yeah.
decriminalization versus legalization.
Correct.
Right, so it's not the same thing.
Correct.
Right? So that's the first statement. These are not the same thing.
Yeah.
Second, decriminalization, you explain it as, like the process of going through the criminal justice system. So you're not going through that system in the same way if we are decriminalizing. You are still being held accountable for your actions, but you are also supported and provided solutions and resources at the same time. So legalization is, everybody can do whatever they want. That's that conversation that keeps happening every time we talk about decrim, is they're not the same thing. the consequences are different, but it's not legal. The consequences are different. So the consequences are more from a health center focus than it is from a criminal focus.
Okay.
That helps.
No, it does. Thank you so much. Again, online, anybody got anything? We good? All right. We'll stop this formal part of her presentation, but I'm sure we can all circle back. She put her email, and I'll make sure that your email is in your social medias. I saw that as well. I'll make sure that I put those things in the minutes so that you can reach out as well. Obviously, now your department is
Public health.
the Department of Public Health. I know that they're very active in the community, and maybe this is something that we can work on to do some more partnerships with. So we'll go ahead and finish that. Thank you so much again. Thank you so much for this very valuable information.
Yeah.
Will we get a copy of your PowerPoint? Is
Yeah,
that possible?
I'll
May
share
I
it with you.
distribute? Okay.
Mhm.
All right. So she just said that she can, that we'll have access to it. You have a couple claps on that.
Thank you.
So, thank you.
Let me see.
Okay, I'll just go ahead and continue with our new business, just to let you know what's going on with our ongoing business. We are still working on the community or the county survey with schools. We're currently talking to a very large school system. And then once their decisions are made, it's going to ripple out to other school systems. We do this every 2 years. We're coming to the end of our drug-free communities grant funding, which requires this survey. But now more than ever, we need to know what our teenagers are facing and how they're dealing with it. We are seeing a lot of self-medicating. We're seeing a lot of, we don't know adults that we can trust. And we really, really want to make sure that we get those messages out about who people, young adults especially, can go to and the help that they can receive. You guys were talking about the senior portion of Medicare, medical care. One thing Ann and I are very passionate about is that we're not seeing it at the other end of the spectrum as well. If you're under 18,
Oh, yeah.
there is a
Yeah.
complete desert. You know, they talk about food deserts.
Yeah.
You know, treatment and recovery deserts, especially for young adults, and that's something that we're very concerned about. I see there's some comments online. I'll be to that in just a second. We are hosting a sticker shock. The Community in Action Group at Lawrenceville, as well as our Incorruptible kids from Mercer County, are going to be doing a sticker shock on Saturday morning at Joe Canals in preparation for the Super Bowl. For those of you who don't know what sticker shock is, sticker shock are these big obnoxious green stickers that you can't ignore, especially if they're on a bright blue box of Bud Light. That reminds people that it is illegal to provide alcohol to minors and to please not be a part of that. And it talks about a little bit about the legalities and the consequences to that. We are having a youth summit at I Play America. It's primarily for our Incorruptible Tobacco campaign. If you know youth that would like to be more involved in that kind of peer-to-peer interaction and talking about tobacco addiction and some of the prevention strategies, and then honestly, now we have a lot of recovery strategies for youth because it's very, very needed. Please let me know. The permission forms are in the back. If you have youth that you know of that you want to take them to. In fact, Ian, would you grab a couple? Because
And I apologize, folks. I'm speaking with the Women's Space for teen dating violence at 10:30. So that's why I have to scoop.
Well, I know you're busy, but if you grab a couple, just because I updated a little bit.
I got you.
So if you have youth that are interested, thank you. So those are those.
Have a good day, everybody.
And then, so now the time is, belongs to the membership. Let me just check this chat real quick.
I think somebody was just maybe saying that they had to go.
Oh, okay. Gomo Health has an announcement. I will definitely put that link on our, I'll put that link on the notes. So thank you. I'll start with those online. If you'd introduce yourself, say what organization you're from, And then if you have any announcements or upcoming events, please let me know. Okay, Al, let's start with you. Just unmute yourself. Can you? Yeah, there.
Yeah, I'm Al Grouper. I'm from the East Windsor Municipal Alliance. I have no comment.
Okay, thanks, Al. We're just glad you're here. Dylan, I know you had some announcements. I'll find those flyers for you.
Yes. My bad. I'm actually. Hey, everybody. Dylan from Right Choice Recovery. Tina's still on here as well. She's the executive director of Right Choice Recovery. We're substance abuse, mental health, and gambling. March is Problem Gambling Awareness Month, so we're hosting a big event on March 15th. I sent over the flyer and the invitation and the brochure to Melissa. All is welcome. We're gonna have a guest speaker and some catered food, so everyone's welcome. Tina, I don't know if Tina's still on, if you want to add anything.
Hey there, I'm Tina Whitcop. I am the executive director here at Right Choice. Just so if anybody knows, here at Right Choice Recovery, we treat compulsive gambling as a primary diagnosis. So if you have a client that suffers from gambling addiction, we have funding through 800 Gambler to provide services to them for individual and group therapy. But we also have services for a family member of a compulsive gambler. So if the client themselves isn't ready to get help, the family member can get help and they can receive treatment also through that grant. Clients that have compulsive gambling and substance abuse, we will put them in our partial care or IOP, and they can utilize all levels of care here and both substance and gambling. But our curriculum for gambling is separate. So we have an outpatient level of care and individual therapy. And as long as they live in New Jersey, they don't have to pay for their treatment for compulsive gambling. Also, we do have telehealth, so they can participate. They can be in North Jersey, South Jersey. They can participate via Zoom.
Okay, and thank you so much, Tina and Dylan. Dario, I will definitely send that out with the meetings or with the minutes. But when I flashed it on the screen, that event is March 15th, I believe, March 15th or March 12th.
March 15th.
March 15th. At your Dayton location, correct? But
Yes,
as I said, I will send that out with the minutes. That might be a great opportunity to just see what this is about, especially during gambling, Problem Gambling Awareness Month. So thank you, Dylan.
You got it. Thank
Carol,
you.
Carol Nicholas. She's a busy woman. We might have caught her away.
Yeah.
Yeah. All right. Let's go with Brooke Beck.
Hi, my name is Brooke. I'm the grants manager for Mercer County Public Health, and I'm just kind of getting my foot wet into the harm reduction community and learning more about the services that are already available in our locality. So happy to be here and listening in, but not much to offer at this point.
Wonderful. Now, do you work with Heather and Sarah? Okay. All right. Wonderful. Glad to have you, Brooke. Nadira Keaton. I was so excited to see your name pop up.
Hi. So I am the program director at Oak Integrated Care, and I see my colleague Carla Bacher is there. Carla is the program coordinator for the outpatient program, and she comes with a plethora of experience in addiction. She was the addictions specialist over on East State Street, and now she's over at our Lawrenceville branch. And she's running things there, and we have some new co-occurring groups. She runs Smart Recovery on Thursday nights from 5:30 to 7. And I'm just excited that we are expanding our services.
Wonderful. Thank you for being here, and thank you for being here as well. Would you like to introduce yourself? She already introduced you, but.
I'm Carla Bacher. I work at the Lawrenceville site, also Integrated Care. coordinator of the program here. And that's basically what I do.
All right. Thank you. That's such a great resource to our community. Thank you so much for being here. Okay, Kruti.
Morning, everyone. My name is Kruti Shah. I am the outreach coordinator for Hampton Behavioral Health. We provide services for inpatient and PHP, IOP for adolescents all the way up to older adults, for mental health and dual diagnosis as well. Thank you.
Thank you, Kruti. Okay, Sarah. She might be busy too. Oh, there she is.
My name's Sarah Gardner. I'm the municipal awareness coordinator for Mercer County. Oddly enough, my part-time job, I'm a parenting therapist. I was actually my supervisor.
Hey, you kind of cut out a bit, but I'll let you. So Sarah is the municipal alliance coordinator for the county. She works with Heather and she works with Brooke. So thank you so much for being here, Sarah. Okay, Dario. Dario,
Good morning. How's everybody? Good morning. Thanks for having me. I work with the Division of Mental Health and Addiction Services. I do program management for several community and family programs in central New Jersey. I can say I'm really happy to see the engagement and participation that Melissa and the team at Mercer Council brings together. And, you know, awesome to see the presentations and the services available. And I share the sentiment of the speaker a few moments ago that mentioned about expanded services. I'm happy to see that there's potential where it needs to be. So thanks for everybody's work in that realm. I'm proud to be part of it with you all.
We really appreciate our work with the state, with the DMOS. Jay Street, do you just want to say hi again?
Hi, everyone. That was a great presentation, Natasha. Thank you. Just wanted to mention that project graduation is already geared up, getting ready for June the 22nd. Melissa is our board on project graduation. Excited. We have our big signature event coming up, Casino Night, on April 22nd, and I will send more information through Melissa's email. Thank you, everyone. Take care.
Hey, Carol, I wanted to give you an opportunity if you're around. I know you're busy. There. Okay, so Carol wears many hats, one of which she is the public health officer at Lawrence. Or no, she works with public health in Lawrence. That's Keith Levine, sorry. But she's busy there. And then she's also the leader of the Greater Mercer Public Health Partnership, GMPHP. And they do some fantastic work around the community. And they release a great impact report every year. And if you want to know something, Carol Nicholas probably knows something about it because she's just so well informed. Dr. Patterson, you want to introduce yourself? I think we know, Dr. Patterson. Yeah.
Rich Harvey, I'm a sergeant with the Ewing Police Department in charge of our community relations unit. I do have two things to bring up. One is this week, our detectives, and actually right now, are out at community living centers in Ewing Township. They're doing a drug take back initiative. And that's a service that we can provide with anybody just with a little bit of notice. We're happy to come out. And secondly, we're partnering with one of our special education teachers for an event on March 4th. With his vision being creating a learning space inside a laundromat in Ewing Township. It's at the Laundry Depot. 1980 Old Avenue. He received a donation of 800 books that he's going to put into circulation, and we're looking to get furniture donated so that when children spend time there with their families, they have access to books where maybe that's not something that's always present for them. And that event will take place, the kickoff event will take place on March 4th from 10 a.m. to 12 p.m. So we're partnering with several community organizations for that, and hoping to make it a success.
Would you mind emailing that flyer?
Absolutely.
Okay, he has a beautiful flyer. There's some here live. Do you work with Bruno?
I do think that's one of my attempts.
Okay, well, we're so glad that you're here. Thank you so much for being here. And as I said, we'll send out that flyer with the minute. This is a microphone.
Oh, got it. I actually really thought you were
It's a microphone.
Good morning, everyone. I'm Jocelyn Cooper. I have a private therapy practice in Pennington, New Jersey. The majority of my caseload is adolescents, but I also work with adults. I'm an adjunct professor at the College of New Jersey, and I'm consulting with Propel and Excel also out of Pennington. I'm glad to be here, and thank you, Natasha, for your presentation.
She's also deeply invested in the success of Mercer County. We appreciate her history, her legacy, and her active participation now.
Hi, everyone. I'm Dickie Camp. I'm a certified recovery specialist with Mercer Council. I'm serving in a couple of roles. First and foremost, primary is running the opioid as the patient navigator for the opioid overdose recovery program, which is sponsored by DMOS. So I'm all about the harm reduction side of the spectrum as opposed to the left side of the prevention spectrum. I'm also stepping into gradually a larger role as director of recovery services. We're looking to expand our portfolio of not only peer services offerings, but integrate with deflection and diversion, harm reduction programs that we can take actionable and tangible steps towards. So I obviously love the presentation today. Love the success stories. Understand that there are caveats to every success story, and trying to work with people to make it to build sensible policies that this agency can help build awareness and implement in the future.
Absolutely. Thank you so much.
I'm Heather DiLorenzo. I work for Mercer County Office on Addiction 23 years now. And
It's not to help us and to do tech support and many levels of information and dissemination throughout the county. And we really appreciate that. Remind me of your name again.
Carla Bach.
Carla Bach.
Oh, integrated care.
Hi,
Julia. I'm here at the Mercer Council, part of the staff of the program coordinator of prevention educators, and I also facilitate weapons life skills training, curriculum education to middle school.
So I'll work in our schools. If you want to schedule those, Amy's the one to hit on. Or you can send it to me and I'll get it to her. We have a new employee here.
Can't see me really online. Hi, everyone. And everyone in person. My name is Caitlin Allen. I am just recently started with Mercer Council as our community engagement coordinator. So excited to come to be visiting the PCMC meetings and getting to know all of you who are really at work in the community. So yeah, it's great.
Well, thank you. Just some legislative updates. We have been working, as I said, with Anthony Burley's office. They've been wanting some scientific basis of understanding THC and cannabis a little bit better. That has been an exciting venture. We also there was a big change with naloxone. I'm sorry, Dave, I'm calling you right as soon as you're leaving. Heather, do you want to talk about the big change with the naloxone in the state?
Yeah, there are a couple of big things that happened in the last year. For those of you who are familiar, every year they began offering for the last several years, a free naloxone day at the pharmacies, but it was one day a year. There were questionable questions about who was eligible for it, if you were in the field or if you were in law enforcement, blah, blah, blah. So there are all kinds of strings attached. Two big things have happened in the last year. One is the development and funding and the implementation of what's called a bulk Narcan distribution program, where basically any organization can quickly register and participate that and get unrestricted Narcan kits in whatever units of 12 in a box you want, basically. We've done several hundred of them and many of the other agencies in Mercer County, so that we've been able to give them out at outreaches and things of that nature where opportunity presents itself. But more importantly, Governor Murphy recently signed into law basically an open pharmacy funding for open pharmacy-based distribution for anyone over the age of 14, no insurance, no copay, no questions asked. You just go in and they will give you a box of Narcan, the nasal variety, and you can walk out with it and use it however you see fit. So the continuing loosening of those Narcan restrictions are definitely, making sure that it is available out there close to where people are using and preventing a lot of their visits to the hospital as a result, if they're lucky.
Thank you. I just knew that there had been a big change recently and that we were very excited about it. Again, one thing I have said from the very beginning is I would rather be trained and have my Narcan kit and never need it than to need it and not have that. So there are several ways to get Narcan trained in person, online. If anybody has any questions about that, let me know. We are going to be starting up our program again, probably next month. So other than that, the minutes will contain some information, some resources that we have, including our TOPS program, which is for athletes or anyone who works with young athletes, talking about the pathways to opioid addiction through pain medication and sports injuries. So if you have any contacts with coaches, physical therapists, orthopedics, young athletes, coaches, Little League teams, you name it, just reach out. We have a great program. We have some great resources for them on how to be a better advocate for themselves as a patient. On the other end of the spectrum, we have a senior program. Lisa has been going around like crazy, helping out a lot of community centers and senior adult health agencies. Again, being a better advocate for yourself as a patient, understanding pain medication and its addictive nature and some alternatives. So those are just a few of the different curriculums and programs that we administer here. Just a report, we have been working with the Trenton nurses recently for a staff training on edibles and different harm reduction measures for younger children. We have seen a rise in middle school usage and concerns about what to do and better ways to get the families involved. We will be doing a teachers in service at Lawrence this month. We are addressing the student assistance counselors like Andy Gennaro and Sharonda and Roswell, who were all on here earlier. We're going to be working with them as well. And I'm trying to think, we're going to be doing another event at Heightstown High School. So if anybody wants to help with those events, anyone wants to see how they're run, or to volunteer to table any of those community events and any more, because it's getting to be springtime. I don't know, the weather doesn't know what to do with itself, but we're going to be out in the community again soon and trying to spread the message and get some community engagement. So if you want to be a part of that, please let me know. We'd be happy to utilize your strengths that way. So with that, are there any other comments or questions? Because we can pretty much end our meeting now. Our next meeting will be the second Wednesday of next month. And while we're at it, go Eagles, go Birds. Go Birds. Yep. All right, I'm going to stop recording now.